Two humorous nurses would like to acknowledge the true custodians of the land in which we record our podcast, the Yorta Yorta people.
We pay our respects to elders past and present and extend our respects to all Aboriginal and Torres Strait Islanders listening today. Always was, always will be Aboriginal land.
SafeStyle makes stylish and practical safety glasses that take you from the worksite to the weekend. Upgrade your PPE today with their stylish and functional range of safety glasses.
Whether you're on shift, on call, first to the scene or in study mode, SafeStyle have you covered. Available in clear UV 400, blue light blocking, transition, polarised and prescription lenses.
We love these safety glasses for their durability and comfort and are excited to share our discount code with you all.
Use our code HUMOROUS10 at checkout for 10% off your order.
That's humorous, HUMERUS10 at checkout for 10% off.
Two Humorous Nurses with Kelly and Alicia.
The podcast that doesn't give ondansetron to patients with a bowel obstruction because that's shitty.
Welcome to Two Humorous Nurses, where we plan to bring you funny, informal, conversational chat about all things nursing. Today I'm flying solo because Alicia's got issues. No. No, she had something come up and we decided we were just going to plow ahead anyway. So today we're talking about palliative care. What is it really? And I have Sarah, who some of you might know, who is my former colleague who's on maternity leave, how rude, and our friend of the pod. Yeah. And she's been bugging us for the whole 3 years. When am I going to be on the podcast? When am I going to be on the podcast? And now she is, and she's nervous as all hell.
Nervous. I've made so many notes.
She's like, I've made a couple, and she's 3 sheets of paper in front of her.
If anyone...
Actually, no, there's 4.
No, but the last one's like your... Like that's not.
Oh, okay. Yeah. All right.
But that's, if anyone knows me, that is just typical me.
Yeah. So Sarah is a palliative care nurse consultant. Is that what that's what it's called?
Clinical nurse consultant.
Clinical. Oh, fancy.
Yeah, fancy.
And an oncology nurse. I didn't put that in originally, but I'm like, you are an oncology nurse. Welcome.
Thanks. Thanks for having me.
Tell us about why, like right back at the start, why did you become a nurse?
Well, I actually really wanted to be a paramedic.
Oh, story of everyone's lives.
Yeah. And now I think about it, like I would make a terrible paramedic.
Oh, you'd be the worst.
But we had like someone from the local La Trobe campus come and cancel us in year 12. And she's like, what do you want to do? And I said, I really want to be a paramedic. And she was like, oh, what do you think your ENTER will be? Which I think is called an ATAR now.
I don't know.
Whatever. That score that you get.
Yeah.
That means absolutely
nothing. Finished high school in the 90s.
Born
you
in
were
the
too.
90s.
Yeah.
So I said, oh, she's like, what do you think your score will be? And I said, oh, roughly 70 to 80 was what I was thinking I would get.
And what was it?
And she literally went, ha! And I'm like, oh. She's like, oh, darling, just apply for nursing. And I'm like, which now I'm a nurse is incredibly insulting. Yeah. But so I just applied to be a nurse because I'm like, no chance of being a paramedic. And then I think I either got 68 or 78. I don't even remember. And that is just a reflection of how unimportant that number actually is for anyone listening.
Yes, very true.
But I didn't really actually want to be a nurse. So I deferred for 3 or 4 years and just worked in retail. And then I witnessed my sister have a C-section when I was like 20 or something, and it just made me really want to be a nurse. Definitely not a midwife. Definitely not. No disrespect to midwives. I think you are absolute angels on this earth, but I don't think I could ever be a midwife. But coincidentally, a lot of midwives when I had Leo used to actually be palliative care nurses. There was like 2 or 3 that were like, oh, I was a palliative care nurse.
It's like the juxtaposition between bringing life into the world and taking life out of it.
Yeah.
Well, you don't take their life out, but, being there at the end or at the start.
Different end of the spectrum. But, so I went back to uni when I was 21 and studied nursing. I did my last big rotation as a student nurse in ED and then my first grad rotation in ED. And I thought I'd absolutely be a crit care nurse, and that was what I was going to do. I loved emergency, which, again, if anyone knows me, would probably shock people because I'm
chaotic.
so like, and
you're not.
I'm so like regimented and routine and spreadsheets and lists, and ED is not like that at all. But I really did love it. But yeah, then I sort of dipped into palliative care a little bit. And yeah, went from there.
And you did your, what did you do? You did grad certificate, or you did
so
grad diploma?
I'd started off, my last rotation as a grad nurse was on like a subacute ward, which had some inpatient palliative care beds. And that's sort of where I got my initial exposure and thought, oh, I really like this. And then we had some of the community palliative care team come to like a grad day we had, like we used to have like self-care days. And they came along and sort of just talked about what they did in the community, and it really just like sucked me in. I was like, hook, line and sinker, that's what I want to do. So I absolutely pestered the crap out of the community nursing num to the point of probably being annoying. And I did some supernumerary days with them, and she sort of put me on to doing my postgrad cert at Flinders. There was no jobs there at the time, but she said, do your studies, and if something comes up, like, we'll keep you in mind. And yeah, so I did the postgrad cert whilst working in ED, like the year after my grad year. And then, yeah, by the end of that year, I was lucky enough to cover some prolonged leave in community pal care. And then, yeah, they haven't got rid of me.
Yeah.
Until now I'm on mat leave. But yeah. But yeah, absolutely loved the postgrad certificate. And then I went on to do the postgrad diploma, which was just another 4 subjects.
Yeah.
But they were all just super interesting and, yeah, really, really good. And applicable to, I think, to all areas of nursing, not just palliative care. Like, particularly the communication stuff was really incredible. Yeah.
Tell me what palliative care is, because when we say to patients, I always say to patients, do you want, you have metastatic disease?
Yeah.
We need to do a referral to the palliative care team. We need to do it early so you can form a relationship, blah, 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 blah.
Yeah.
But then they're like, but I'm not dying.
Yeah.
And you're like, no, no, you're not.
Yeah. Yeah.
But that's not what palliative care means. But everyone thinks palliative thinks dying.
Absolutely.
But that's palliative care is a big, broad thing.
Yeah.
Okay.
And that is so when we have students working with us, or I'm doing any sort of education or anything, that is literally the first key message that I tell people, that palliative care is not just end of life care. You'll hear people all the time say, oh, they're palliative, they're on a syringe driver. And I think the most important thing we can do is say, are they end of life care or are they palliative? Because another really important message is that people can still be having active chemotherapy or immunotherapy treatments or even radiotherapy whilst on a palliative trajectory. And I think that is a really common misconception, and that leads people to think that palliative care is just end-of-life care. It's absolutely not. It is such a huge umbrella of care. It's symptom management, it's quality of life, it's caring for the carer. And that's, I guess, what community palliative care is helping people to be at home and helping them to be well, helping them to, live their life and to do the things they enjoy. And obviously when it does come to that time that they're deteriorating, end-of-life care is a huge part of what they do as well. And community palliative care helps support people who do want to die at home rather than in a hospital or aged care setting. I should also add, community palliative care also caters for people in residential aged care because that is their home. And
yes, I didn't know that until you started working with us and we had a nursing home patient.
Yeah.
And and I didn't think that their pain management was enough or the right thing. And and you were like, you should do a referral palliative care. I'm like, but they're in an aged care facility.
Yeah.
And she's like, no, exactly. You should still do it. That's their home. And I sort of thought, I never thought about that because aged care doesn't necessarily know or have there's not always doctors available to help with their pain and their symptom control and things like that.
Yeah.
And we do a lot of preemptive, and that's how we sell it to them. We're like, we're trying to keep you home as long as possible with support because eventually your symptoms are going to become to the point where you need
Yeah.
more help. And I'm like, I can help you in here in the hospital, but that's it.
Yeah.
Like, I don't do your home stuff.
You
like,
need, and I guess that's the thing. Like, it's everything that you can do in a hospital, they can virtually do in the home.
yeah.
Within reason, I guess. But, the services can link with a whole array of other services, physio, OT, social
Yeah.
work, all of that sort of stuff. They liaise with your oncologists or, and the other important thing is it's not just for malignant patients too. There's this whole, area that's up and coming for palliative care for people with dementia, which again is something that is under-referred.
Yes.
And it's super complex for carers to manage people with dementia in the community. And there's so many supports out there, but people just don't know where to find them. And that's where being linked with a service like community palliative care is really helpful because they are sort of your coordinators and your centre, and they can reach out and get you everything you need.
Like, that's a really good point, that it's not just for people with cancer.
Yeah.
That it's for any chronic illness that's terminal.
Yeah.
So your COPD.
Yeah. Heart failure, dementia. I've got baby brain. I can't think of it.
No, but there's like so many of them.
Oh,
like,
there is.
I think, and that's important because people just assume if you've got cancer, then you need to. And that is the majority, but it's not everybody.
I think, I'm trying to think back when I did a bit of project work in 2020, I think it was. And I reckon the ratios were something around like 80% malignant, 20% non-malignant. But that was back then. And I mean, that could have changed by now. But that's another really common misconception is that, like, people with non-malignant illnesses can't be referred, but they absolutely can. And I personally find them the most complex ones to manage, particularly your COPDs, because they have that up and down trajectory. Like, they're really well until they're not, and then they come back a little bit, and then they get really unwell again. And, they're quite tricky to manage.
I had a webinar this afternoon with the consultancy in Bendigo, the longest name consultancy for your regional, what is it, Loddon Mallee Regional Palliative Care Consultancy.
It's like another letter in there.
And they showed the trajectory of, from like well to death for people, like traumatic, so it's like fine and then down. And then, it showed like chronic, like COPD, how it's literally up and down. So cancer's like a really steady decline. And there was something else, and it was like sort of all over the place.
I think they have one for dementia.
Yeah. So there was 4. And I thought, that really, it just shows that there's always a time and a place for these, things.
Services,
and that there's a lot out there.
Yeah.
That people don't know about.
Yeah.
And so every like health region has a palliative care area. So like even with the Loddon Mallee one, they showed how many different areas had community palliative care.
Yeah.
It's quite timely we're doing this today, actually. I only watched it this afternoon. I had the Loddon Mallee Special Interest Group webinar. I was awesome. I was zoomed in on that. It was a palliative care consultancy group telling us about what they do.
Yeah.
And I was like, that's really, they have nurse practitioners and everything. Like we just recently had a patient and she prescribed antiemetics and things for him that he couldn't, because he couldn't get into his GP.
Which is so common.
Story of our lives.
There's actually there is a need. So we know in our area that there's massive gaps with the GPs, and I'm sure it's the same everywhere. There is such a need for nurse practitioners in palliative care, and particularly in residential aged care, that is literally a whole other podcast I could bang on about for days about palliative care in resi aged care. But the doctors and the access for those residents is so poor.
Yeah.
And it puts so much stress on those facilities and those staff. And good palliative care and good symptom management should be their bread and butter because sounds terrible, but my nan used to call nursing homes God's waiting room.
No, exactly.
And it should be, it should be their gold. It should be what they
aim for.
Yeah, absolutely. But that access is an issue.
No, of course.
Yeah.
I mean, it's an issue for us healthcare workers who know how to use the system.
Yeah.
So imagine if you're like incapacitated or you
Yeah.
have limited ability. Like anyway,
Limited
that's a whole
health. Yeah.
that's a whole other podcast.
That is a whole other
I've been
podcast.
rolling around in my head thinking, how can we do that? But anyway,
Yeah.
what's your favourite part about being a palliative care nurse?
Oh.
I mean, I know you love it
Yeah.
because like you bang on about
I
it
bang
all the
on
time.
about
Yeah.
it all the time. It's so cliche, but the people. I just
Yeah.
love working with the families and the carers, and I don't think you get much more vulnerable than when you're dying. And just to see, like, I mean, some families are not great, but that's just a given.
Life. Yeah.
But to see just the pure, like, unfiltered love that people have for their loved ones and the care that people give, like seeing grown men, farmers wiping their dads, backsides.
Yeah.
And, stuff like that they would never do, but they just have so much love for this person. And it just brings out, like, we all know that death brings out the best in people and the worst, but it really is just, the connections that people have and witnessing that. And I think it's just a massive privilege to be able to, play a part in that.
Yeah.
And yeah, I just love it.
I think midwives get all the glory because you bring new life into this world and it's a beautiful experience. And we won't talk about the stuff that could go wrong in those moments where brand new life is not there or things go wrong. And we've both had not pleasant births, so we we know how that can go. We underestimate the power of being there at the end.
Yeah.
Like I don't want to do community palliative care. That's not for me. But I love palliative care within a hospital when you can like make their make their death peaceful.
Yeah.
And I think it's people are so scared of it. And I'm like, no, just embrace it. Like
people are scared of it. And I remember when I told my mum I was going to do palliative care, because I'm the type of person that if I'm like down the street and I see an old man eating alone, like I'll be in tears. Like I remember Sean and I went to the movies once and there was an old man alone sitting behind us, and the entire movie, like I couldn't even tell you what the movie was about because I just kept turning around to like check on this old man. And I'm like, oh my God, his wife's probably dead. And Sean's like, his wife's probably annoying as shit and he's left her at home because she was going to talk the whole way through the movie. Like, shut up. And so when I told my mum that I was going to do palliative care, she's like, oh, I don't think that's for you. Like, I think you'll be too emotional. Like, you're going to want to bring everyone home. Like, but I've actually found it really easy to... Yeah, I've just adjusted to it, and I think it's just because I do feel like it's such a privilege, and, I don't take it for granted that people do allow us into their homes at what is the most rawest, hardest, difficult time in their life. And I don't like the term a good death because I don't know. I feel like every death is sad and horrible for the people that it affects.
Yeah.
But, dying can be a beautiful thing.
Yes.
And, some people find it really peaceful and are at peace with it, and some people aren't. They fight it and fight it and fight it. But yeah, I really love it, and very passionate about it.
Yeah.
Yeah.
I love that. And just on that, the letting it go, do you think, because, we're both very empathetic people, and I think, we work in industry or in specialist areas that sometimes we do take it home with us. How did you learn to let it go or be at peace with it?
It's funny because working in the two different areas, I found that my emotions are very different. So working in oncology, when we have patients that, we're seeing them off to, go have end-of-life care or we're stopping their treatment because they're at that next stage of their trajectory and they're deteriorating, I often find that harder to deal with than I do losing one of my palliative patients for end-of-life care. And I don't actually know why that is. I've thought a lot about it, and I don't know whether I have in my head that in oncology we're treating them and we're helping them, but then in palliative care we're treating them and helping them but in a different way. I really don't know what that division is.
Yeah.
But I think just being able to talk openly about it, and that is like the key, I think, to being able to cope with all the, you know, the difficult things that do come with the job, is like our team is just incredible, and our manager is incredibly supportive, and she just seems to be so intuitive. She just knows when we're, you know, teetering on the edge and and when we're not. And yeah, I think just being able to speak openly about, you know, things that might be triggering you or affecting you. And yeah, I think the ability to decompress after a shift is really important.
Yeah. How much time do you spend sitting in your car in your driveway? A lot.
I feel judged. I think the longest I spent sitting in the car after work one day was about 45 minutes, I reckon.
Yeah.
And just put the seat back.
Yeah.
And then sometimes Sean would come home and I'd be like, oh God,
better get out.
look busy. But yeah, I do a lot of just sitting in the car decompressing. I don't know why the car is different to my lounge, but I don't know.
It's
Must
just
be
the effort of getting out. Yeah.
The 10 or so steps to get inside.
I think it's interesting when we talk about death at work as well, like especially when it involves our patients, we're a little bit more like, you know, like it's been we do have that little bit of attachment, whether we're treating for palliative care reasons or for curative reasons.
Yeah.
I think it is a little different to a palliative care patient.
Yeah.
Because I mean, I don't think you would bond any differently to the patients. It's just that you're giving them treatment maybe.
Yeah.
And then, you know, from a palliative, and we don't joke about death with those we would never joke about with them, but about, you know, like when we decompress. But with palliative stuff, we tend to maybe say little jokes that if other people hear us, if you're not a nurse and you hear a nurse, do not judge them.
Yeah.
Like they have probably done the most traumatic things. So if they're cracking a joke about cracking a rib or, you know, like just let it go, right? You've not walked in their bloody Crocs.
And I sort of feel like as a nurse, you have to have a bit of a twisted sense of humour sometimes.
Yeah,
like,
I think that's why people like us.
Yeah.
Isn't it? People like to drink with us because we are fucked up. Like,
and I think that's why some patients like bind to us as well. Like because they know, like the ones that want to have a laugh about it. Like,
and they come in, you ask how they are, and they're like, no, half dead today. You're like, oh, great. Don't die here. Die on the footpath. It's too much paperwork in here. Oh my God. So in our culture, like death is so taboo. Yeah. It's a topic that we just don't talk about. People die. We don't like to mention it. We don't even know what to say to people.
We don't say their names ever again.
Nothing. Like it's so, you know, whereas in other countries and not even like even Western countries, they put them in the front like lounge room.
Like on McLeod's Daughters.
Yeah, for days on end, just so the town can come and say their goodbyes. That's what I expect everybody to do. I expect you to put me out the front, light a bloody fire pit, eat some tacos. You'll be cold because the fire pit has to suck.
I'm going to draw a mustache.
And then, and then have a margarita. No. But why do you think that death is something that in 2023 we still struggle to talk about openly?
I think because it's an emotional topic, and as a society, like I think that's evolving, and I think, you know, in time that will change. But I think people just don't like to talk about things that are going to upset them.
And uncomfortable.
Yeah, absolutely. And I get it. Like I do. Like who wants to sit down and say to your mum, well, when you die, like what do you want to do? But I think the best gift you can actually give your loved ones is telling them and letting them know what you would and wouldn't want. There is nothing worse. And I've been in that situation when you're standing there and you've got to make a decision for a person that can't talk for themselves.
Yeah.
There's nothing worse than not really knowing what that person would or wouldn't want. And then you're the one that has to live with the repercussions of that. So, yeah, if you were having a conversation with your mum and or your dad or grandparents, friend, partner, whoever, and you should be having these conversations with everyone, no matter how old you are, because shit happens. You know, if something horrible happened to you, would you want to be left in a unfunctionable state? Like, would you want to have to rely on people to give you 24/7 care? And you know, they go, oh, God, no, I wouldn't want that. Or you might think they wouldn't want that and they say, oh, no, that'd be okay as long as, that's fine.
I can blink. We'll be right. Yeah.
Put me in the front room. Like I think that is the most important thing. And even the little things like, you know, what music you want to play. Like I remember this one patient that I cared for, she'd had this whole conversation with me about the music she wanted, and I'd said to her, have you spoke to your family about that? And she said, no, because I'm afraid to, because they'll get upset. And I said, well, that's okay, but they might want to know. And she still couldn't bring herself to do it, and that was fine. That was her prerogative. And then she passed away, and one of the daughters rang and she said, oh, Mum told me that she told you what music she wanted, and we never talked about it. She couldn't. And I'm just wondering if you remember. And I'm like, yeah, I remember. And, stuff like that. It doesn't have to be about the nitty gritty stuff. Sometimes it's the little things that are really important to talk about, because they're the most important things. But yeah, I think people think that palliative care is just about dying, but it's really about living, and that's where good palliative care and good community palliative care comes into it, because it's managing those symptoms and caring for the carer. That's a huge part of what community palliative care does as well, is supporting the carers, making sure that they can live well and do the things that they love, spend time with the people they love, and stuff like that.
There's a great video on YouTube, and I think I've talked about it in a previous thing, the 1,000 days.
Oh, yeah.
What would you do if you only had 1,000 days left?
Yes.
I think we watched it together when we were doing some education or something.
In a webinar or something.
Oh, and we were so emotional.
Yeah. It's the people walk past and it
has
says
their
how
numbers.
many days they have left.
And 1,000 days is literally 2 and a bit years. Imagine knowing... Is that right? 3 and a bit years. Oh, my maths is terrible. If you only had 1,000 days left, how would you spend it? And it's when you have a terminal diagnosis of whatever, whether it's, COPD or cancer or anything, just that doesn't mean you're going to die immediately, but it may mean you only have 1,000 days. So how are you going to spend that? And if palliative care at home, whether that's just some support for the carer or support for you, or bringing in a shower chair because you can't stand anymore, or some nutritional support, then that might make those 1,000 days better. And that's a good video. I'll link it in the show notes, but it's actually worth watching. It's a beautiful, it's quick. It's only a couple of minutes.
It's very insightful and quite confronting, actually.
Very confronting,
But I think the best way to put it, if you had 1,000 days and good palliative care started on that first day, could get you to the 998th day, living your best life. Yeah. And then 2 days of, end of life care. Yeah. Then absolutely consider it as an option. I think so many people are quick to push it away because, again, they think it means, I often say to people, dying. When you go for that initial visit and you're introducing, and you can tell they're just a little bit standoffish, and I often say, people think we're the Grim Reapers, but we're really not. We're here to really help make your life easier, and
that's exactly what it is. That's why I always say it's support. It's like they're doing the job that I do in here to help you within the hospital. They're doing in the community, in your home, with your family.
Absolutely.
It's just.
And I think during COVID, community palliative care played such an integral part, because, people were in hospital and they weren't allowed to have people visit, and those multidisciplinary discharge meetings and all of that, it didn't happen. And the discharges home was so complex because, we didn't know that there's steps at every entrance because OT couldn't go home and do the visits, and it was really hard. But you go into the home and everyone can be there and you can have those conversations, and it's so important to go through all those bits and bobs. And
during COVID, did you find that more people died at home than in the hospital because they could have their family with them?
So I was doing project work for a big chunk of COVID.
That's very
so
true.
I can only sort of pass on, I guess, the last year and a bit, really, which COVID was still a thing and restrictions were still a thing. But yes, a lot of people who were otherwise very, very unwell and probably would have and maybe should have been in hospital were choosing to be at home because they could be at home with their loved ones. They didn't want to come to hospital and not, see their loved ones for the last time. I can't remember the statistics off the top of my head, but a huge number of people choosing to die at home instead.
Can you tell us about dying at home? Because I don't get it. What do you do?
So basically, you do everything that you do in a hospital. So community palliative care play a huge role when people want to have end of life care at home. There's so much coordination that goes into it, organising all the appropriate equipment so they can get things like hospital beds and, providing continence aids and every big thing you could think of, down to the little things like a basin and a face washer so that they can have bed baths and stuff like that. Obviously, when people are needing subcut meds at home, that's part of what the team do as well. And that's often educating the families how to give them. Obviously, the nurses can only be there for, an hour out of 24 hours. And the rest of the time it's up to the family. They're the ones there overnight, giving the care and giving the subcut meds and all of that. So, and syringe drivers, managing all of that, manage pretty complex symptoms at home, nasogastric tubes, fluids if needed. Lots of stuff, more than I can even think of off the top of my head. Another really important part of providing end-of-life care at home is educating the family. And again, about all the big stuff like giving medications and symptom management and, they might have pain and nausea, but you've got to make sure that you've educated them about secretions and things too, because that's going to happen in the middle of the night. And if you haven't explained that to them, it's going to catch them off guard and they're going to panic. So really just thinking about every possible scenario and then accounting for it. The other big thing we educate families about is what to do if someone, when someone dies at home, when someone actually passes away. And that might actually differ depending on your organisation's policy. So I can only...
Because they're admitted under your hospital as or they're not?
No, they're just a community patient.
Okay.
So basically, the community palliative care team will do the groundwork with the GP, making sure the GPs are on board and aware that the patient's receiving end-of-life care at home. And 9 times out of 10 they will be, because they'll be writing the medications and giving the orders, and we'll be giving them updates regularly. The other important thing is to make sure they're happy to sign off on a death certificate, which, again, 9 times out of 10 they are. Every now and then you have issues if a GP is away, or it's a patient that doesn't have a GP, which surprisingly happens a fair bit. And that's when it can get a little bit messy. Obviously, these deaths are what we call expected. So you don't need to ring an ambulance. You don't need to ring, the police or anything like that. Sometimes people panic and do ring an ambulance when their loved one has passed away, and that's okay. And I think from experience, often they just make some calls and they'll find out that it was an expected death. But there have been cases when a patient has been sort of relatively stable in their palliative care, and their death has been sudden, not unexpected, but sudden. They might have had a PE or something like that. And sometimes that can be a bit messy because an ambulance is called and then the police will be called. But usually those things can be smoothed over and, after discussions with specialists and things like that. But, that might change. I have heard of organisations that it is the policy that they need to ring an ambulance and the police. So it might just be worth checking. Depending on where you're working.
So would the family then so say it was the middle of the night and you don't call palliative care or anything like that. Do you just call family just call a funeral company direct, and the funeral company sorts out the death certificate and everything?
So within our organisation, if it's overnight, we encourage the families to call our after hours team and just notify them.
Sure.
So that they can let the pal care nurses know. We then encourage them to call the funeral director whenever they're ready. Some people want to call them within half an hour, and some people will keep them till the sun comes up, whatever they're comfortable with. And then, the funeral director, if it's out of hours, will come via ED or, urgent care, depending on what town they're in, and have the patient verified.
Yes, I've had to do that twice.
Yeah.
It's the most weird thing when the doorbell rings and from the ambulance bay. You're like, why is there a hearse in my ambulance bay? Can you just come certify this? And I was like, certify what? I'd never done it before. I was like, I don't know what I was supposed to do. And he's like, just tell me they're dead. And I was like, just give me one moment.
I remember the first time I was ever working in ED and a hearse pulled up, and I was so confused. This was before I worked in palliative care, and I'm like, Have we missed a
It's
step
a little
here?
late.
But yeah. See, the things we laugh about.
I know, it's terrible.
But if it's during the
God.
day or within like working hours, they can call the Palcare team.
Yeah.
And the nurses will go out and certify the patient and often help the family wash and sort of
Oh, that's
prepare the
lovely.
body, which is
Yeah.
actually a really lovely thing
Yeah.
to do. I find it really, particularly if you've been heavily involved with a patient and a
Yeah.
family, it's a nice little bit of closure, I think.
Yeah.
It doesn't happen that often because I feel like people tend to die overnight.
Oh, I know, how rude.
Yeah. But it is a really nice thing to do. And it's nice for the families too, I think.
When I was in Perth, my stepmom was like, "You have to watch this episode of Australian Story. You have to watch it. It's on a funeral company." And I was like, righto. And it was on this funeral company, and I cannot for the life of me remember what the name of it is, like Harmony or something like that. And they're like a not-for-profit company in the Northern Rivers region of New South Wales. I could have that completely wrong. Anyway, it's some hippie kind of town. And they have created like a community-based, it's not Nimbin or Byron Bay, a community-based funeral company that's low cost.
Yeah.
If you can afford, you pay, I think it was like $250. If you can't, then people's that have previously paid. And they go in the home and they prep the body. They do the whatever they want them to do for the like one person that died was an artist and he wanted everyone to paint his coffin. And so they just got a cardboard coffin because that's what he wanted. And like, and
do you
it
know
was,
that they're actually not that cheap?
no, I know. They're not as cheap as
Yeah.
I was expecting them to be. That's what they were saying.
I
They're
had
like,
a patient that was adamant on having a cardboard coffin, and then when he found out how much they were, he was outraged.
oh, he's like, just collect some boxes from Bunnings. I thought, oh, that's such a beautiful, because funerals are so ridiculously
Oh, they are.
overpriced and they're stuffy and gross. And
It's like weddings.
oh,
As soon as you add, as soon as
yes.
you say funeral, it's like dollars.
Yeah. It's like you need a $10,000
Yeah.
casket to be buried in
You
or
need-
burnt in.
You need gold handles.
I was like, it's too bad you can't rent one, be in it, and then get chucked in the like. Anyway, maybe I'll start my own company. So
probably make a lot of money from that.
yeah, I don't have this in the questions, but the way you were just doing the whole talking about when people have died in the home and you can go in.
Yeah.
Palliative care doesn't just stop when the patient dies either,
No,
do you? You have a
absolutely
whole bereavement part of it too.
Yeah, so that's a huge part of what we do as well. So bereavement follow-up and support. And, you know, some people, you'll ring them, you know, we often ring sort of after the patient has died, and depending on when that is, it could be within 24 hours.
Yeah.
It's a weekend, you know, whatever. But we ring and just check in, offer our condolences, and you know, just see if there's anything in that immediate instance that we can do. We then sort of follow up within a couple of weeks after that and offer a home visit where we actually go and have like a bereavement visit. And again, that gives us a chance to assess how that person is coping, how they're managing, or people, I should say, because often it's more than one person. And, you know, offer resources and that sort of thing. And then we follow up again at the 3-month mark and again at the 6-month mark.
Yeah.
If there's any red flags in that time, we send off referrals. We do more intensive follow-up depending on what they need. And then at 12 months, we send a card to say, you know, that we're thinking of you. We know it's been a year and that sort of thing. Some people are fine. Some people don't want anything.
Yeah.
Some people you ring and they'll be like, nah, I'm fine. You know, I'm good. I've got good family support. Other people you ring at 3 months and they'll be fine. You'll ring at 6 months and they'll be fine. And then at 9 months, they ring you and they're in an absolute mess. Yeah. And that's the other important thing. We stress to them all the time. You can ring us anytime. Our care hasn't just stopped because, you know, your loved one's passed away. So, yeah, that's a big part of what the service does as well. Yeah. And I think that is important for some people because not everyone has family support. Not everyone has people that, you know, check on them. And I think the other thing is, and it comes back to us, what we were saying before about people not wanting to talk about death, is people don't want to talk about grief either. No. People don't want to, you know, say, like, I was reading a thing today actually. It was like, you know, don't stop saying their name. Don't say, oh, how are you? Say, how are you since you've lost Bob, you know.
Yeah, acknowledge their
it.
loss.
Yeah, absolutely. And I think that's really important to people as well, is that they don't feel forgotten. And I think that happens. Like, you know, people stop bringing casseroles, people stop,
that's right. They
making
stop
phone
popping
calls.
by.
Yeah.
I think that's such a lovely thing too for you to be able to have that ongoing because there's nothing, and that's probably the one thing that we lost a patient in July and all I wanted to do was reach out, but he did not die in our hospital. It's not my job to call the family to make sure they're okay. I probably could with this family and it would have been okay, but also, you know, like,
you don't want to set a precedent for what you have to do for all other families.
And the family did ring me to let me know that he had passed, and that was nice. But then, and then I was just like, I couldn't stop thinking about them because I feel like we'd seen them so regularly for nearly a year, and then they just gone, and then, you know, just before Christmas, his wife and his daughter came into the hospital and they front desk rang and they said, they're here at the front. Can you come out? I was like, send them down. And she's like, no, they can't come down. And I was like, oh. And so when I went to the front, they stand there crying. So I'm crying before I even get to them. And I was like they brought, you know, a card and they brought his funeral things. And his funeral happened really quickly too. So we didn't even get a chance to, I missed it online. And, you know, like sometimes I would never attend a funeral unless the family asked, but being online, like it's actually quite nice.
Yeah, you
we
can
could see it.
Yeah.
And then, you know, and she brought like chocolates and she brought like a little Christmas thing for Amelia because she always bought something for Amelia. And she was just said, I can't come down there. I'm so sorry. And I was like, I can't believe you've come over here. Like, she said, well, it's taken me all year. Like she was just like, I'm like, I couldn't come any sooner. And I said to her, oh, I'm so glad you came. Like I wanted to say I'm so sorry and give you a hug. And it was really lovely to say, you know, and it hasn't hung around with me since. But not everyone wants to do that. Like I know there's one person in our community and I will literally leave I left Woolworths the other day because I saw they were in there and I was like, I do not want them to see me because I know they don't want to see me.
Yeah, we're too triggering for people at times. And that happens in palliative care too. Like I have rang people for bereavement follow-up and they've just said, look, I'm doing okay, but your calls are a bit much for me at this point. Yeah. I know where you are and I'll ring you if I need you. And that's okay too. Yeah. Like you've got to, people are allowed to set boundaries. Yeah. Like,
and you know, and that's, you know, that's ballsy for them to say too.
Yeah. God, yeah.
Yeah.
I would just be like, oh, no worries.
Okay, thank you.
And then
talk to you in 3 more months.
Then hang up and cry for 3 days. And then when you rang the next 3 months, be, oh, I'm so glad you called.
And and I don't know if this is everywhere, but your service also held a like a ceremony, don't you? Like a yearly thing where to acknowledge everybody.
Yeah, which is beautiful. And COVID sort of put a different spin on that, but we adapted and did it differently, which was still really beautiful, but not the same. But that again is just a really beautiful way to bring everyone together. They read out the names of everyone that has passed away. And, you know, everyone's invited to light a candle and, you know, people come and just really love it. And I think it's really good for us as a team as well. Like it's quite nice to see everybody and there's no pressure around, you know, going up and having conversations with people. They approach us if they want to and they don't feel pressured to come to us. And it is really beautiful. And they've done some amazing work in the bereavement area over there. Like they also have a bereavement walking group, which is amazing, which is set up purely by that team. And, you know, some great friendships have been formed from that group. And, that's just, really good.
I think that's something that we like you said, the grief, you know, we think of palliative, well, not in palliative, just dying. Yeah. But then we don't think of that impact of grief and how, you know, because that grief affects everybody. I mean, some people can get over it, and I don't mean get over it just to get over it, but I mean the grief to a point where they can live their life again very quickly. Yeah. Whether they've grieved while they're in that palliative phase, and then it's a relief and they can move through the phases really quickly, or they're stuck in it for years. Especially I think if the death is quite quick and you know they think they have more time, or you know, And I think we're going to try and do it. We've got quite a few death care type topics coming up, and I think grief is something that we're going to have to try and cover, even though it's hard to talk about.
Yeah, it is. But I find grief really interesting as an emotion. Because people just handle it so differently. And one of the most important things I learned in my postgrad cert, we did a whole subject on communication, where if anyone is thinking about studying palliative care, I really highly recommend the Flinders course. It's just incredible. And you actually do a 2 or 3 day intensive at Flinders University where you do simulations around communication. And one of the most important things I learned from that was, and I use it in my everyday life, not just at work, is that how people treat you and how people act is more about how they're feeling than what they think about you as a person. And that applies so strongly to grief. And anticipatory grief more so. I think that people don't really realise they're grieving before their loved one has died and how that can affect them as a person. People often say, I'm sorry I spoke to you like that the other day, or I'm sorry that I did this, or, I'm sorry that I snapped when you called. And it's oh, God, it's
And that
fine.
probably happens a lot with dementia and Alzheimer's type patients where they lose the person before they die.
Yeah.
And that grief. So by the time they have passed, it's probably more of a relief factor than it is the grief.
And I think burnout is a huge thing for people caring for
Care
people with
burnout
dementia.
is intense.
Oh, yeah, absolutely. It is.
Yeah.
And that's and that's another really good thing that community pal care do as well, is linking in with carer support and Carers Gateway, which are a really great resource. That's, as I said, caring for the carer is a massive thing.
Yep. No, that's very interesting. What advice would you have for nurses who are thinking about going into PAL care? You mentioned Flinders Uni for your post-certificate.
Yeah. I think if you have an interest in it but perhaps haven't done any work in the area, it's definitely worth, seeking out some experience in the area. Make sure it's your cup of tea.
Yeah.
Because it's not everyone's cup of tea.
Yeah.
Like I said, midwifery is not my cup of tea.
Yeah.
It's important to, I think, find your feet and gain a bit of experience in the area. Make sure that you do cope with it emotionally. I remember I was working with someone once and we were sort of preparing a body and they said to me, they're like, I just don't know how you want to do this for your career. I don't know how you want to do this. And that just reflects that, everyone is different. Everyone's built a bit differently and copes with things a bit differently and views it as I view it as a beautiful thing and other people don't, and that's okay. But I think absolutely getting some experience. So PEPA or PEPA, I never actually really know what PEPA is a really great placement experience. I think it's palliative experience. I can't even remember what it stands for. But you can apply to do a placement through them and they match you with a service. And I believe that you can do half the placement in an inpatient setting and half in a community setting.
Oh, that's cool.
Or with a consultancy service. So I highly recommend that, and you can literally just Google that and I think you just send them an expression of interest.
Just live Google what the PEPA stands for.
Program of Experience of the Palliative Approach, I reckon.
Wow.
Am I right? I should know. That's embarrassing that I don't.
Keeps coming up, Peppa Pig.
I mean.
Oh, yeah. Peppa Pig. Some live music while I Google. Palliative. The Program of Experience in Palliative Approach.
Yeah.
Wow.
Yeah. So they also do reverse placements too, where they'll send a consultant to your hospital and provide training and placement.
Wow, that's really cool.
Yeah. So I know one of my colleagues has done that and found it really valuable. So that's good. Banksia Palliative Care also provides some really great education. And then obviously if you're wanting to sort of step further and do postgrad qualifications, I really recommend Flinders. Some of the subjects, I did 8 subjects in total and I can't even remember them all, but they were just, really helpful. And like I said, quite applicable to all areas of nursing, not just palliative. And I think that's the other thing as well, is that I think in whatever area you work in, you're going to come across death and dying, even in midwifery.
Yes.
Like, I think that people forget that. And, it's such, I feel like it's something that should be covered more. Like, I don't even really remember learning or doing anything about it at uni.
No.
And that's what frustrates me about aged care is we're sending these PCAs or care assistants in to do, you know, aged care work, which, let's be honest, a good portion of aged care residents probably should be on a palliative trajectory, not end of life, but a palliative trajectory. And they've got no education about symptom management.
I need to be on Peacock.
Yeah, they do need to be on Peacock. That's a whole other thing I could rant about for days. Google Peacock if you don't know what it is.
PCOC.
Yeah. It's amazing. And yeah, like I just think it should be one of the core things that people learn. It's inevitable. Like we're all going to die at some point.
Yeah. And it should be part of I think it's really undereducated in all areas, but as you say, in aged care, I mean, there's only one outcome for your patients in aged care.
Yeah.
I
mean, I've only ever known one aged care resident to go home.
Yeah.
And it turns out her dementia was post-op delirium. That's why she went home.
Oh, and delirium's not great.
No, it wasn't. And I think medical too, like I don't know how much education is given to medical around palliative care and symptom management, but that's why we don't give ondansetron to people with bowel obstructions.
Yeah.
Junior doctors.
And if they're bowel obstruction, check for spinal cord compression.
Yeah. Oh, I could do a whole podcast on spinal cord compression.
Thanks for.
Oh, wait, I want to add something else.
Oh, okay.
Because I remember ages ago you had someone message and ask about whether it's okay to cry in front of patients.
Yes.
And I just want to say that it is okay to show emotion in front of patients. I think it shows that you're human and sometimes it's nice for them to see. But I think within a professional capacity, I think if you're like sobbing and the carer is comforting you, that's a red flag.
I think a red flag.
Red flag. It's absolutely okay to show emotion.
Yeah.
And I think that's how you form connections with people. And again, like I said, you're in people's lives and in their homes in a really vulnerable time and they need to know that you're human.
Yeah.
So it's okay, but don't steal all their tissues.
Yeah. Just
subtle.
Have a tear.
Subtle. Just a subtle little wipe.
Subtle little tap.
And then get in the car and
bawl your eyes out. Yeah. Sit in your driveway for 45 minutes.
Go buy some sushi.
Yeah. A $20 salad from Nourish. Yeah. Shit, I just knocked over our trophy.
Oh.
God.
Do I get a trophy?
Georgie Carroll Life, we're inaugural champions.
Yes.
Thanks for joining me.
Thanks for having me.
Yeah.
Finally.
It was a bit like, finally. Now you have to listen to your own voice.
Oh, God.
Wonder if Leo will laugh
will love
in the
it.
car. Yeah.
I was saying to Kelly that we always listen to the podcast on a Wednesday morning on the way to rime time. And I swear Leo just knows the sound of Kelly and Alicia's laughs. And
Sarah had her baby on my birthday.
Yeah.
And she didn't even leave me a Facebook and Instagram story for my birthday. She was too busy pushing out a baby.
Kelly fully jinxed me.
Yeah, I mean,
it's your fault that he came.
I told you weren't going to make it at 36 weeks.
What did I say? If you said to me, if you make it past 36 weeks, I'll eat my shoe.
I didn't have to. Yeah,
and I had him at what did I have? Oh no, 34 and 6. I was going to say I had him at 35 and 6.
Yeah,
but it was 34 and 6.
Very close.
So I had a week's grace.
Anyway,
I'm not eating your shoe.
That was really, I love talking about that. I like palliative care. I like dying. I don't like dying. I like talking about dying, and I want to have more conversations in this area.
I think it's important to talk about it so that people,
especially as nurses.
Yeah. God, yeah.
Like we have all seen someone die, and if you haven't, you're going to.
Yeah.
Before the end of your career.
Yeah, absolutely.
But before you die, go and rate us 5 stars on the podcast platform you're listening to us on. Oh, that's so funny. And follow us on Instagram at 2 Humorous Nurses, or send us your story to email hello@2humousnurses.com. You have to say bye with me.
Okay.
Bye.